I'm Dr. Rebecca Todd with the University of Kentucky Department of OBGYN. This video will demonstrate how to perform a pelvic exam. We will highlight the components that each student is expected to perform during our clinical skills workshop. For this video and for the clinical skills workshop, the student will use a pelvic model. A volunteer will participate to simulate physician-patient interaction, proper patient positioning, and proper draping. During an actual patient visit, the medical student would introduce herself, clearly define her role, and obtain a thorough history. She may also perform other indicated aspects of the physical exam. For the purpose of this video, we will assume that this interaction has already occurred. At this point in the visit, you should instruct the patient to undress from the waist down, put on the gown, and place the drape over her lap. Excuse yourself from the room while she changes. Preparation is essential so the pelvic exam is smooth and brief. Extend the footrests on the exam table. You should familiarize yourself with the equipment at your particular clinic. Place your supplies within easy reach: speculum, lubrication, gloves, and any indicated tests. Ensure your light source is functional. Your facility may have a gooseneck lamp or a light attached to the speculum. Always clean your hands. Help the patient into the proper position on the exam table. If your facility provides a pillow, move it under her head. Some patients require more assistance than others. Her heels should be on the footrests and her hips should be on the end of the table. Ensure that the drape covers her upper thighs. We recommend adjusting the drape to allow the patient to see your face. Throughout the exam, it is helpful to tell the patient what you are doing. Avoid sudden movements. Ensure that your facial expressions remain pleasant or neutral. Always wear your gloves and change them if necessary. Touch the patient's thigh before moving to the vulva. The examination of the external female genitalia includes the mons pubis, the labia majora, the labia minora, the clitoris, the urethral meatus, the vaginal introitus, the Bartholin's glands, the perineum, and the anus. Depending on the patient's individual anatomy, you may need to retract parts of her vulva to properly examine each of these areas. The Peterson speculum comes in several sizes and can be plastic or metal. The Graves speculum has a wider bill than the Peterson and also comes in several sizes. Each speculum has a handle, a lower blade, an upper blade, and a thumb hinge. The lower blade is longer, is attached to the handle, and remains stationary. The upper blade is shorter and moves when you press the thumb hinge. There is a locking apparatus on the thumb hinge. The metal speculum has a knob and uses a screw mechanism. The plastic speculum has an angled teeth and uses a ratchet mechanism. The speculum handle can be adjusted to move the upper and lower blades farther apart. The handle lock uses the same mechanism as the one on the thumb hinge. We caution you about opening the speculum too wide. If you are having trouble visualizing the cervix, repositioning the speculum is better than opening the blades wider. The speculum exam is the most difficult to master and is the most likely time to cause the patient some discomfort. We recommend practicing the mechanics of the speculum. If you are comfortable with the tool, then the exam will be easier for you and the patient. Apply lubrication to the speculum. The urethra and clitoris are very sensitive. Avoid hitting them with the speculum. Always aim posteriorly when inserting the speculum. Hold it at a 45-degree angle for insertion. Once the speculum is fully inserted, rotate it and open slowly. You may need to separate the labia to insert the speculum. If you have trouble with the upper blade opening before insertion, try placing both blades between your fingers. The goal is to insert the speculum below the cervix, raise the upper blade, and allow the cervix to drop into view. Gently maneuver the speculum until you can identify the cervix. Once you have completed your cervical inspection, slowly remove the speculum. Be careful not to close the speculum too soon because the cervix may be caught between the blades. Be careful not to close the speculum too late because the upper blade may hit the urethra. Inspect the walls of the vagina as you withdraw the speculum. Ensure the speculum is closed by the time it exits the vagina. During the bimanual exam, you will palpate the pelvic organs between your two hands. Ensure that you use adequate lubrication. Introduce 2 fingers of your dominant hand into the vagina. Palpate the cervix. Put your 2 fingers under the cervix and lift the uterus. Use your other hand to press down on the abdominal wall above the pubic bone. Palpate the size, shape, and position of the uterus. Next, put your 2 fingers into the right apex of the vagina. Use your other hand to sweep down the right lower quadrant and palpate the right ovary. In a similar way, put your 2 fingers into the left apex of the vagina. Use your other hand to sweep down the left lower quadrant and palpate the left ovary. Be aware of the patient's facial expressions during the exam, as this will help you assess her level of discomfort. If you have very large hands, you may only be able to use 1 finger during the bimanual exam. Once the pelvic exam is complete, you should properly dispose of your supplies and assist the patient into the seated position. Instruct her on the location of tissues or wipes. Excuse yourself from the room while she gets dressed. Not every physician performs the pelvic exam in the same manner. We have used the APGO guidelines as the foundation for our exam today. These guidelines also serve as the basis for our clinical skills workshop and checklist. You may learn several excellent tips from your instructors throughout the rotation. Please incorporate these tips into your future practice.